Module 1, Perioperative Nursing, Postoperative Phase. We will be discussing all that your role entails as the RN taking care of a post-op patient. So the postoperative phase starts right after the patient is done with the surgery, and it will continue until the patient returns to the surgeon for their follow-up appointment. After a patient has received anesthesia, they will go to the recovery area called PACU, or post-anesthesia care unit. These patients are considered unstable, so they require close observation after any type of anesthesia they've been given. Another priority would be to control that post-op pain and to prevent complications. So that's what we're going to focus on. Before we get into our assessments, just a little bit about the different PACU settings. So depending on the type of surgery or the facility you have the surgery in will determine what type of PACU setting you go to. So your textbook describes 4 different settings. Now, in real life in the hospital, it may not be exactly like this, but it's good to know the differences. So first we have our inpatient PACU. So this is probably what you picture a PACU looking like. When the patient comes out of surgery, they go into a big room with a bunch of beds, and then once they have, quote, recovered, then they go to the inpatient floor where they will continue to recover. Then we have the ICU setting. So this is mainly for patients who have really, really invasive surgeries that are very, very high risk. And they basically leave the surgery and go straight to ICU, and that is where their PACU recovery time begins. There is an outpatient PACU, which, just like the name says, you're having an outpatient procedure. It's very similar to the inpatient PACU, where there's a bunch of beds and everybody's together, but these patients are going to go home. They're not going to be back, going to a inpatient floor. And then we have procedure areas. So for example, if a patient has a procedure like a colonoscopy, they typically will hang out there until they have recovered and then they go home. So it really depends, and these are not set in stone. These are just kind of like general terms. So we have 3 phases of PACU care. So phase 1 is right when they get out of surgery. This is where they're most vulnerable. This is where they're most unstable. So they are going to have routine vital signs like every 15 minutes. They're going to still be on a cardiac monitor. Okay, I mentioned this before in pre-op. So in pre-op, they're going to be on a monitor, and in post-op, they're going to be on a monitor. You're really going to focus on those priority organ systems. So the cardiac system, respiratory, and neuro. Okay, so those we're going to be really making sure we're checking that heart rate, the rhythm. We're going to be listening to lung sounds. We want to make sure they are still breathing after they come out of anesthesia. And then our neurological function, you're going to be doing level of consciousness, so making sure that they become alert and oriented, because they're going to be groggy and it's going to take them a bit to kind of come back up to their baseline. We're going to keep an eye on the surgical site. We don't want that to bleed out. And pain. So pain is expected after surgery. So you should have lots of things that you can do for that, whether it's non-pharmacological like repositioning or thermal, hot and cold, something like that, or medication. Because we have expected symptoms to happen, you should already have PRN medications available to give. And temperature control. When they come out of the OR, they're typically cold, so we want to warm them up with warm blankets or a bear hugger. That is a machine connected to a puffy blanket that blows warm air to keep you warm. So after they become more stable and they meet a certain criteria, then they go to phase 2, where they're now considered stable and ready for discharge. So criteria is going to focus on the ABCs. So the patient is awake and they can manage their airway. They're breathing fine. They have adequate oxygenation and their vital signs have returned back to baseline. They are stable. So that means that they are ready to go to phase 2. So overall, the goal is to stabilize the vital signs, let the patient wake up from anesthesia, and make sure their pain is controlled. Then we go to phase 2. So phase 2, since they're no longer considered, quote, unstable, they don't need as much monitoring and they are ready to either transfer back up to the floor or discharge home. And the focus is then going to be, okay, where's your ride? Get your stuff together. Let's change you into clothes. That is phase 2. The home discharge criteria from the PACU is listed here in this box from your textbook. For the most part, it's pretty much the same for most facilities, we want them to be awake. Again, vital signs, neuro assessment is as baseline. They're able to tolerate liquids without nausea or vomiting. All right, so after surgery, we expect the potential patient to be kind of nauseated and or vomit. That's kind of something that can happen to some patients after receiving anesthesia. And again, we have medication to help with that. So we are not going to hold back. We are going to give the meds. But by the time they go home, we don't want them vomiting anymore. So that should have already been resolved. Pain relief should be controlled. Patients should be able to walk safely, or if they were, for example, wheelchair bound, they should be able to get in the wheelchair and go home. So whatever the baseline was, that's how they should return before discharge. And then you can read through the other criteria. Phases. The next phase will be the final phase 3. Now, not everybody reaches phase 3 because phase 3 happens when there is like the patient has technically met that other criteria, but maybe there is no bed available for the patient to be admitted to. So the patient's pretty much stable, everything has been reached, but they can't leave because there's no bed available. So they're just kind of waiting, or maybe their ride isn't there. So it's just kind of like this, a phase, a what if phase. A delay in discharge home is anticipated after a same-day surgery, can often be caused by uncontrolled post-op nausea, vomiting, or pain. So phase 3 also includes that patient that didn't have their pain controlled like we wanted and is still continuing to have nausea and vomiting. So that can also be part of phase 3. And we're going to talk a little bit more about that in a second. So now we're switching back. We're done with the phases. Now we're going to talk about patient care in the PACU, what your responsibilities are, what our priorities are. Priority assessments. Okay, so the patients in the PACU, of course, we want them breathing, airway patency. Patency, always think, okay, head of the bed should be up and they shouldn't have secretions blocking the airway. So they may need suctioning. Respiratory status, we're going to auscultate the lungs. We're going to check their pulse, their oximetry. Oh, there's a typo. It says viral signs, but that should be vital signs. Neural function, temperature, skin color. Are they pale or do they look back to their baseline? Pain, condition of dressings. So after surgery, sometimes there is some saturation on the dressings, but you don't want it to be, too much. Condition of visible incisions, patency of their IV lines and drains, hydration status. So in Skills Lab, you went over the care of a JP drain. So if a patient does have a JP drain or any other type of drain, you need to keep your eye on it. We want to make sure that it is flowing, it is not obstructed, and we're going to empty it per facility policy. Sometimes the surgeon they do not want you to empty that drain post-op. They want it to be emptied, 2 hours later, 1 hour later. So that part can actually vary, but your responsibility is just to keep assessing that drain. And hydration status, especially if the patient has a lot of nausea, vomiting, your hydration status is going to be very important. And then again, I mentioned extubation of an ET tube. So once they're being extubated and they're removing that endotracheal tube that was used, to hook up to the ventilator, that can actually cause some trauma in the airway and that can lead to edema or laryngospasm. And again, laryngospasm, if both vocal cords start spasming, the airway will shut. So you have to have that emergency equipment at the bedside. Continuing on with patient care in the PACU. Some diagnostic tests that might be performed postoperatively. Now, these are normally not done on routine surgeries that don't have any complications happening. If the patient is stable and they're recovering as expected, we typically don't do additional labs or chest x-rays or, EKGs, ECGs, unless we have some kind of issue or that specific surgery requires it. So some labs that may be done post-operatively include checking for bleeding. So that would be your hematocrit and hemoglobin, your H&H, your fluid status, your electrolytes, your kidney function, and your clotting factors potentially. So for example, if you have a patient who had surgery on their leg and now their site is bleeding a lot and there really isn't a reason for it, then they might do a stat coag study, PT, PTT, INR, just to make sure what's going on. Or maybe the patient would require a chest x-ray post-operatively. Maybe they inserted some type of line, like a central line or some other type of tube or something that they just want to check function for. They may do a chest x-ray postoperatively and an EKG if they came in with, an extensive history of some type of cardiac issue and they want to just run an EKG just to make sure the patient is okay. That is a reason why they would do that. Now, this table 17.1 from your textbook outlines the reason for each test really well. I want you to take a look at glucose. So glucose will often be checked even if the patient is not diabetic. So of course, if the patient is diabetic, we are doing automatically, we're going to check their glucose. But if a patient is not diabetic, or if they are and they've had maybe like a change in level of consciousness, or they're kind of lethargic, one of the things we want to rule out is hypoglycemia. So maybe it has nothing to do with their airway. Maybe they're having a hard time waking up because they're so hypoglycemic. So that's a time where we would consider glucose as being maybe the culprit. So that's why glucose is on this table. Pain management in PACU. So we expect pain. You just came out of surgery, they just cut you open, and sometimes some surgical procedures we expect way more pain than others. So this is where we need to give medication and make sure we do our non-pharmacological interventions, and we could possibly give a patient-controlled analgesia. So we went over this in Skills Lab, so here it is. You should be familiar with it. I think all of you are well versed in the education that the patient should have for this and the RN role when it comes to setting it up, checking it, and troubleshooting and assessing your patient. Remember, it can cause respiratory depression, so we really want to make sure we're doing our neuro checks frequently, our respiratory system checks frequently. And moving on to post-op nausea and vomiting, or PONV for short. So this isn't just regular nausea and vomiting. This is like excessive that really isn't managed by medication or anything that we're doing. So this can lead to severe dehydration, electrolyte imbalance, wound dehiscence, especially if you've had an incision on your abdomen and then here you are vomiting a lot. You're going to have that separation of the incision. It can lead to aspiration. You can stay longer in the hospital. It can really cause a lot of issues. And if you're sent home that way, you're just going to come right back to the emergency room and end up in the hospital again. So risk factors, this is evidence-based risk factors. If you're young, you don't smoke, you're female, you have history of motion sickness, just getting general anesthesia and high doses of neostigmine, which is a medication often used in the OR, you could potentially have this adverse nausea and vomiting that just won't stop. So treatment. We want to minimize post-op opioids because opioids can lead to nausea and vomiting. We want to make sure the medications we're giving are appropriate and effective. So if something isn't working for that patient, we want to quickly let the doctor know so that they can change it up. Multimodal pain management strategies. This means we're not just going to give morphine. There's other medications. Maybe the patient would benefit from Tylenol and more, that's just a random example, but we want to try different approaches. And then prophylactic antiemetics. So we already know that patients have a potential to be nauseous after they come out of anesthesia. So instead of waiting for them to say, I'm nauseous, why don't we just give the antiemetic just to avoid that from happening in the first place? Now, when a patient has nausea and vomiting and it appears like what you're doing isn't working, we want to consider that the patient may be developing an ileus. Now, I know you covered ileus in Med-Surg 1, so what is an ileus? Well, an ileus is when your bowels just kind of they go to sleep, they get frozen, they stop moving. And the reason why that is not a good thing is because our bowels are always moving. There's always peristaltic waves that move things that are in our bowels the right direction, which is out, right? So if you have an ileus, that means a piece of your bowels are silent and frozen, and whatever's in there, whether it's gas or fecal matter, nothing's gonna move and it's gonna get backed up. It's gonna get backed up and it's eventually gonna make it to your stomach. You're gonna get bloated, you're gonna have abdominal distension, discomfort, pain, and nausea and vomiting. So if the patient is experiencing nausea and vomiting and they just had this big surgery, then you want to suspect an ileus. So you're going to get your stethoscope, you're going to listen to bowel sounds, and you're going to make sure the patient has bowel sounds. If you hear nothing, no bowel sounds present, that could be an indication of an ileus. That's something reportable to the physician. That is not normal. That is not expected. We do expect hypoactive bowel sounds because they just had anesthesia, but we should never have absent. Absent is an abnormal finding. So some other post-op complications that what we look for is respiratory depression, pain, and bleeding. So we talked about respiratory depression. We want to make sure they wake up. You want to raise the head of the bed. You're checking the vital signs, that heart rate, respiration, the pulse ox. Pain, we are asking them the PQRST, where is your pain? What is your level? And then after you give the medication, you want to make sure it was effective. Bleeding / hemorrhage. So bleeding is a big one. After any surgery, doesn't matter what kind, you have the potential to bleed. And sometimes we don't always see the blood on the outside. It can be internal bleeding. So very important that you remember your vital signs for this one. You will have a change in vital signs very early when you start to hemorrhage. So you take the vital signs, you suspect the patient is bleeding and you can't see it on the outside. So what are the vital sign changes you are going to see? Your heart is going to start compensating for the loss of volume by beating faster. So you are going to see tachycardia. With the low volume in your blood vessels, that will cause hypotension. So the classic sign, and remember this for your entire nursing career and all of your exams that you're going to have in nursing school, when you suspect a patient is bleeding or hemorrhaging, you're going to see tachycardia and hypotension in your vital signs. Very important, and that happens early on. So vital signs are so important. And then, of course, as the body continues to compensate, your respirations will go up as we're trying to get more oxygen in the system. But tachycardia and hypotension are going to be those telltale hallmark signs of hemorrhaging. Your nursing management continues with your overall assessment, so your neuro, your vital signs, your peripheral pulses, temperature, and color. So we want to make sure circulation is intact and blood flow is intact, especially when you have a surgery on an extremity. So if you have a surgery on your femur, on your knee, you're going to want to do a really good neurovascular assessment distal to that area. So distal means the farthest away from your core. So for example, if you had knee surgery and you're taking care of a patient who just had knee surgery in the PACU, recovering, then you want to make sure the most distal spot, which would be like your foot, has circulation, because that means that all those vessels in between are intact. So you can use the 6P: pain, pulse, paralysis, pallor, paresthesia, and pressure. So pain, you're going to ask the patient, can you feel this? As you touch there, yes. Pulse, you're going to check for pulses. They should be equal bilaterally, palpable. Paralysis, is it moving? Can they not move it? Pallor, you're looking at the skin color. So if it's pale, that can be an indication that circulation has been compromised. Paresthesia, that is when the patient has like a tingling, pins and needles sensation. We think neuro with those types of descriptions. And pressure. Pressure refers to compartment syndrome, where they're perhaps bleeding out on the inside and it's putting pressure, and it's just very, very like when you push down, there's a lot of pressure, and the patient will say, I feel like a lot of pressure. So those are the 6Ps, very important, especially on limb surgery, but we're going to include this in our assessment because that can also be an indication of DVT. So we want to check for pain, pulses, all of those things. And then urine output, another very important assessment. So of course, we're going to know if the patient's baseline has a normal GU function. So were they continent, or did they have history of retention? After receiving anesthesia, it can affect our neuro system. So sometimes those nerves, and just for sake of lecture and layman's terms, the nerves kind of go to sleep. So the nerves sometimes need a little time to kind of wake up and start functioning how they're supposed to. Or if the patient had an indwelling urinary catheter in place, again, the body needs to realize, oh, I need to start working again. They just removed it. So we want to make sure there's adequate urine output. And if you remember how many mLs per hour a person should have is 30. So anything below 30 mLs an hour can be reportable to the physician. And of course, that's generally speaking. Some patients, the physician will give you orders. Let me know if the patient has blank output. But for our purposes, they should have at least 30 mLs of urine output per hour. And if they don't, then you're going to have to do some more focused assessment in that area, which we'll talk about in a second. Pain, we want to make sure their pain is effectively managed. So you're asking the PQRST like we mentioned. And then again, we're checking the skin, we're checking that surgical site, and any other wounds the patient has. Things that you want to make sure when that patient comes out of the OR is that you connect them to a cardiac monitor. That is one of your top priorities. One of your top priorities is a cardiac monitor. Okay, we need to make sure that they don't die on us. We want to start the admission assessment immediately. You're going to do your head to toe and any other documentation your facility requires, vital signs, handoff from the OR. You want to make sure, what time were they extubated? What time were those medications stopped? What were the vital signs inside the OR? Did they take the blood sugar? All of that information is very important. Continuous monitoring. So you are not going to be down the hall for an hour. You're actually going to be able to see your patient in recovery and be checking on them at least every 15 minutes. You're going to provide the medication as ordered, whatever the doctor wants you to give, you're going to give those medications. And then you're going to prepare the patient once they're stable to go to the inpatient floor if that's where they're going. We're going to use SBAR. SBAR is a standardized tool. This is again a standardized tool are meant to reduce errors, to streamline processes, to make sure nothing is missed. So that is the type of communication tool you should be using in general, but especially in this situation. Teaching, you are going to teach the patient, you need to cough and deep breathe. You want to set them up for success. So any kind of information related to the specific to that surgery, you want to convey to them. You want to keep communication with the family. Hey, the patient just got to recovery or to PACU, and we'll give you an update when you can come see the patient or when the patient will be transferred to the floor, whatever the case may be. You want to give them some information about visiting. So research has shown having the patient's loved ones, family members with them actually leads to better outcomes during the healing process. So if the facility allows that, we should definitely invite that per hospital guidelines. Now, once the patient leaves the PACU and they go to the inpatient unit, so say you're working on Med-Surg and you're receiving the patient from the PACU. So now there's another protocol in place. So technically the patient is considered more stable because they now left the PACU, but every hospital has a certain protocol. For example, if you are the Med-Surg nurse and you're receiving a patient from PACU, on your unit, you may need to take vital signs every 15 minutes for 30 minutes, and then it changes to, every hour for 2 hours, and then it continues to whatever your hospital protocol is for that unit every 8 hours. So you follow hospital protocol, but you want to make sure what the patient's baseline is. You want to make sure you have all your orders for your patient. When your patient returns from a surgery back to the unit, it's kind of like a new patient because they've had a change of condition. So all of their orders are going to change. If you were on Med-Surg and your patient was going to have surgery, you prepped them and then you sent them down to surgery. When they come back to you after surgery, it's like a new patient. You have to do your full assessment again. You're going to have to check your orders. They're going to change. Their activity orders are going to change. They may be on bed rest for a day or a bed rest for 6 hours. They may be on a clear liquid diet when they come and we'll advance it as tolerated, stuff like that. So everything is going to be reset. We're going to focus on pain, nausea, vomiting, just like they were in PACU. We're going to keep an eye on their vital signs, and we're going to do a complete head-to-toe assessment. So a little more detail on some post-op complications that could happen related to the respiratory system: atelectasis, pneumonia, pulmonary embolism. So atelectasis is collapsed lung. So pneumonia, as you know, is an infection. Oftentimes it can be related to aspirating things that shouldn't, high risk for aspiration. And then pulmonary embolism, this is when we have a blood clot that travels to the lungs. So for atelectasis and pneumonia, incentives barometer is your best friend. Please go back and read how to educate a patient on how to use this step by step, very important. And all of these things can lead to inadequate gas exchange, hypoxemia and hypoxia, and eventual death if you don't do what you need to do. And I have a picture here of someone walking a patient down the hall. Early ambulation movement is so helpful with our respiratory system. It helps to expand the lungs, it moves your muscles. So whenever we can encourage early ambulation, if it's not contraindicated to the surgery, we are pushing that. In our cardiovascular system, electrolyte imbalance, tachycardia, vasoconstriction, especially if the patient received some vasopressors during surgery, dehydration, blood loss, and clots. So we're going to keep an eye on that and make sure that we're doing our DVT prophylaxis, whatever that may be according to your orders, the sequential compression devices, the early ambulation, um, fluid, making sure that their fluid status, they're not dehydrated, because when you're dehydrated, your blood gets real sticky, it doesn't move well, that can lead to clots. And then here I have a little light bulb, something for you to remember. You want to avoid placing any type of pressure behind the knees or having the patient dangle their legs for long periods. So if you have a patient in bed and you want to elevate their legs, you should elevate it so that it's under their calves, so their heels are floating. You shouldn't put the pillow under the knees. When you put it under the knees, it creates like a triangle shape, and that can lead to pooling of the blood. When blood pools, not only that, but also it decreases venous return because it's at an angle and the blood can't circulate back as well. And this is especially important with patients who already have a pre-existing condition related to circulation. Pooling blood congeals and clots. So, and it kind of like stagnates, and that can lead to blood clots. So definitely don't put anything behind the knees of your post-op patient. Then we go to our neuro system. Some complications that can happen are delirium. And remember the difference between delirium and dementia. So delirium is acute and it should be able to reverse. This is very common in older patients. And there have been a couple times where I was taking care of a post-op patient and I had to call a code gray because the patient just was combative as they were coming out of surgery. It was temporary. Patient got medicated. A couple hours later, they were back to their baseline, walkie-talkie oriented times 4. So very common in the older population. Post-operative cognitive decline. Yes, sometimes some patients experience this irreversible cognitive decline. It is one of those risk versus benefits with anesthesia. So takeaway from here is make sure you're doing your neuro checks, making sure your patient doesn't have a change of condition. Keep asking them, do you know where you are? What brought you to the hospital? Do you remember? All of those neuro checks that you're familiar with. Next is our GI system, and we talked about this a little bit. So with anesthesia, your GI system can slow down, your bowels can stop sometimes, and that is called an ileus, especially when the surgery was actually on the stomach or the bowels. So those organs do not like to be touched. They don't like to be manipulated. So when you have surgery and you're messing around with those bowels, they tend to just stop and freeze up and stop working. So again, even if you haven't eaten, you still have stuff in your bowels. You have fluid, you have secretions, and you have old food in there. And all of that stuff will get backed up, cause problems in your stomach, distension, can cause a bowel obstruction. It's not good. And oftentimes that will manifest as nausea and vomiting that is not relieved by anything that we do. So get your stethoscope out and listen to bowel sounds. Ways to kind of hopefully prevent this, especially in those high-risk patients, is early ambulation, repositioning the patient, trying not to give them a lot of medications that could lead to constipation, like opioids. And this, of course, this is when at all possible. Sometimes we can't avoid these things, so we just have to be really diligent to catch this early if it happens so that we can report it to the doctor and it can be taken care of. Next is our urinary system. Very common, you may experience urinary retention. This can be related to the anesthesia, opioids that we use, or even just plain old immobility, or if the patient has had that urinary catheter in place for a long time. So every hospital has their own protocol, but typically after you remove a urinary catheter, we give the patient some time to urinate on their own. Usually it's 6 hours. If the patient hasn't urinated on their own, we may do a bladder scan. So bladder scans are nurse driven. You do not need an order for a bladder scan. You may have an order for a bladder scan if the physician wants you to do it at a certain time or a certain interval, but you can check that. I hope that you have seen this, but if you haven't, you will soon. They do an ultrasound and it gives you a rough estimation of how much fluid is in the bladder. This is not a perfect machine by no means. Sometimes it gives false readings, but it's a nice tool to have on hand. So if it is indeed you find, there's a lot of urine, more than whatever your facility considers large, because there is no standard amount, then you'll need to tell the doctor and possibly get an order to get a straight cath or maybe to put in a Foley catheter. So it really just depends. But your role is to make sure that they are voiding and that they're urinating at least 30 mLs an hour. Skin, integumentary. We want to avoid complications. So this is going to include dehiscence, evisceration, and surgical site infection. So you're not going to see an infection in the PACU because it's too fresh, but you may see it once a patient goes on the inpatient floor. So what does infection look like? In simplest terms, it's going to look angry. The site's going to look angry, really red, really inflamed. It could be edematous. It can have oozing, purulent drainage. It can have an odor. Dehiscence is when those two pieces of skin that were sutured or stapled or glued together that should be approximated. The word approximated means that those two pieces of skin come nicely together. They start to dehiss and come apart. Evisceration is when something comes out. Usually it's going to be like a bowel will come through. So all of those things are not good. So overall, your assessment, you're going to do a head to toe, all of these things mentioned here, respiratory vital signs, peripheral perfusion, that is going to be your circulation check, your 6Ps, neuro check, GI check, your GU check. You're going to keep an eye on the skin and the drains. So here's a picture of the Jackson Pratt drain. So just a couple things. I know you went over this in Skills Lab. That drain, that bulb should be kept below the wound. So it shouldn't, if you have a wound, on the side of your abdomen, it shouldn't be kept on top of your abdomen. We want gravity to kind of help drain that. And this bulb it works on negative pressure. So after you empty it, you need to squeeze the bulb, put the stopper on so that it can slowly pull from that cavity, that liquid coming out. We're going to monitor pain and keep an eye on our food and electrolytes via our labs. Actions. So all of these things we pretty much talked about already. Respiratory care, that's coughing and deep breathing, that's encouraging and teaching the incentive spirometer, suctioning when appropriate. Fluid management, follow doctor's orders, give IV fluid. Once they're able to drink fluids, you can provide them with water. Mobility, early ambulation is key. DVT prophylaxis, diet management, we're going to follow doctor's orders. Usually it's clear liquids until they can tolerate some more consistency. Keep an eye on the wound. Pressure injury prevention, fall prevention, of course, standard fall precautions, managing constipation. So we want them to make sure they're getting in enough fluid. They may need a stool softener temporarily post-operatively, especially if they're getting a lot of pain medication. And we are to remove that Foley catheter. So those urinary catheters, 99% of the time are only placed temporarily for the surgery itself, and then it's removed after. Sometimes patients do not want you to remove that catheter because it's really nice to stay in bed and not have to go to the bathroom because when you move it hurts, but they are very high risk for infection and we don't want to give them a UTI. So that comes your education, and yes, we do have to remove that catheter usually within 6 hours after the surgery. So some miscellaneous teaching that you should also keep in mind. You want to educate your patient on what to expect when they're in the hospital. I'm going to be coming in every 4 hours to take your vital signs. Our visiting hours are from blank to blank. Our charge nurse name is blank. Here's your call light. Here's how to order food. Lunch comes at this time. Safety topics, of course, we want to make sure they call before they get out of bed. They know where their bathroom is, what their diet's going to be, stuff like that, whatever specific to that patient. And then discharge education. So we want to avoid having the patient come back to the hospital at all costs. Not only should we be avoiding that because the patient should be ready to go home and have all the knowledge to take care of themselves, but hospitals get dinged when patients come back within 30 days because that means something was missed. There shouldn't be a reason why they're coming back if they were discharged in a stable condition and all their needs were met. So discharge education is really important. If they have a family member or a friend or somebody, their caregiver, they should be present during that education so everybody's on the same page. And here's a couple of pictures that you can kind of look through, another one and another one. And that concludes this lecture.